Okay, welcome to this webinar. This is a webinar that's been pre-recorded. Apologies for those of you who want to attend the last week. Unfortunately, I had a bit of a family crisis at home and was unable to commit to that session. Unfortunately, to record this earlier rather than later, so at least that way you've got an idea of things that we're going to be talking about. This month we're going to be talking about MUR tips again, and this time we're going to be talking about diabetes type 2. Now, my intention today is not to go over all the clinical bits and pieces with regards to diabetes, etc. You can easily find that elsewhere, and we've done that in the past as well. But today is really to go over what diabetes type 2 is, in terms of what the sort of things you should be looking out for in an MUR situation. So the usual format that we've done, which has worked quite well, is the mind map format here. I mean, again, you can download this. If you want this mind map itself, you can download it from the clinical mind map section of the website. If you want to listen to this webinar, obviously you're doing it now, but you can listen to it anytime you want in the future as well, and it's going to be all online for you too. The idea today is that I'm going to be going over diabetes type 2, specifically relating to MUR tips. There's 6 branches that I'm going to be concentrating on. First of all, the medication issue, which is, one of the main reasons why you'd want to give an MUR to anybody really. We're going to be talking about concordance, diagnostic screening, we'll be talking about some lifestyle tips, about some places where you can post people to necessary, and finally we're going to be going over something called the sick day rule. So in other words, if you are type 2 diabetic or patient with type 2 diabetes, what would you do in terms of the medication that you take if you are ill, and obviously your testing regime as well if you use it. So, quite a fun-packed day, quite a fun-packed webinar, I should say, if you believe that's fun. But let's make a start now, okay? So first of all, medication issues. Now, I'm going to be going over the 2 main types of anti-diabetics, the sulfonylureas and the biguanides. For those of you who don't know, biguanides includes, well, the only main one is actually metformin. We're also going to be looking over some of the other anti-diabetics, the glitazones, insulins, and very briefly we'll be going over Zemtide and some of the newer agents. For those of you who don't know, we've also got a webinar as well on the Zemtide and newer agents, quite an extensive webinar, so I'm not going to be concentrating on that particular area at all. We're going to be looking at the first 4 there, but if you do want to find out more, have a look back on the webinar section, and you'll find this particular webinar there as well. Now, with sulfonylureas, we'll be looking at 4 different areas. We'll be looking at the side effects, the 2 different types, the longer acting and the shorter acting ones. You'll find that the shorter acting ones tend to be now the most common ones that are used. And so, just to bear in mind that sulfonylureas are often add-on therapy to metformin, where metformin is contraindicated. They can also be used on their own as well, but generally you would start off with metformin and then maybe move on to sulfonylureas if your diabetes isn't being well controlled. But anyway, that's the way you would tend to look at this. Now, sulfonylureas, there are a few main side effects that you need to be aware of. First of all, there's a greater chance of hypoglycemia occurring, in other words, low blood glucose occurring. That tends not to happen with metformin, mind you, and that's one of the reasons why metformin is generally preferred as opposed to sulfonylureas for first use. There is an issue as well with weight gain. Not just seen in metformin, but again, that's more common in sulfonylureas. And also, you get the general GI even disturbances, the gastrointestinal disturbances. the one obviously are these two here, weight gain and hypos. You might need to test or check how many times the patient tests their blood glucose, and weight gain as well. I mean, if that is a big issue, then you may need to move on in terms of the diabetes pathway. But those are the two main issues that you'll probably experience more than anything else. Now, the two ones tend to include glibenclamide. Because longer acting, we would generally tend to avoid them in the elderly, but I'll be very surprised if you see many patients on glibenclamide anymore. There tends to be a move now towards the short-acting ones, tolbutamide and gliclazide. I've highlighted gliclazide in yellow because that is the most common one that you'll tend to find now. Simply because the shorter acting, well, mainly because the fact it's shorter acting as well, and less prone to hypos as a result of that. So there's a couple of things there in sulfonylurea, just to sort of refresh your memory on it. As for the big one, let me just close this branch off a little bit, and this one here. As for the main one there is metformin. Now, the issue that you're gonna find with metformin is the GI disturbances, and that could be reduced by taking with food. If a patient comes up to you and says, look, I've got really jippy tummy as a result of these tablets, you could try that out. There is some evidence to suggest that the MR version may be slightly more, less pro, I should say, to giving you GI disturbances, but they're a hell of a lot more expensive as well. So that's another possibility as well. So if they're taking it with food and still get the GI disturbances, you could possibly say, well, have you tried a modified release version? The incidence of hypos and weight gain, they're better generally because of that in elderly patients as well, because they don't have hypo effect generally. But one you've got to bear in mind is hepatic and renal failure. They don't work very well. Well, they do work in actual fact with patients with renal failure, but it depends what stage they're in. But with a renal failure, you would tend not to use metformin at all. So just bear in mind, and the chances are you probably will not see anybody in the pharmacy with these two anyway at any serious level. But you can probably see for yourself that metformin tends to be the nice one of the two to use. Bear in mind as well that a patient normally just on metformin does not require very frequent blood glucose testing, and you'll probably see a lot of surgeries nowadays have reduced their test strip usage, especially in this sort of cohort of patients. Primarily because it doesn't really have much instance of hypos. You will probably see it in patients with sulfonylurea, but not so much in patients with metformin. And surgeries generally have done a lot of work. It's actually, I think, mentioned in the QEP as well. It's one of the targets, national targets anyway, for medicines management to actually reduce test strip usage in suitable patients. So patients generally just on metformin will tend not to use blood glucose strips too much. In terms of others, there's been a huge amount of publicity with regards to glitazones. It's no longer generally recommended, especially with patients with heart failure issues, and one of the casualties in the glitazones, for example, was rosiglitazone, which was withdrawn, and and pioglitazone as well also has similar sort of issues with it as well. So bear that in mind as well. Patients with glitazones, if you have any issues with the heart, with the particular patients, I mean, again, I'm very likely that you'll see one, but it's just something for you to bear in mind. Insulins, we put that a lot last time round, but I'm going to go into it in a huge amount of depth. But it's the last line in defence, the patients who've got diabetes. One particular issue with the MUR that you may be concerned about is somebody who's actually recently starting off in insulin and issues with DVA. It may actually affect their livelihood to a certain extent as well, because they've got to report that to the DVA, and there could be issues, for example, especially if they're lorry drivers or they drive something which is reasonably heavy duty. They might not be allowed to drive that anymore, so that's a big issue there. And also with the insulin, because of the way it works, you need much more regular testing of your blood glucose as well. Again, we're going to go over the Xenotide and the newer agents. These are things that we've covered in a previous webinar. So if you're very curious about that, which I hope you are, you can look at the previous webinars and go over that. So that is like the medication issues that you would probably experience. Some of the concordance, the practical sort of things that you may want to talk to about is confirm the regime and the dosage on the MUR form. So in other words, is the patient taking what you think they're taking? They're taking their metformin 3 times a day, and when it says so when they're taking it 3 times a day, when they're actually taking it once a day. So that's something you might want to talk to them about, because it's quite common in actual fact for a patient who has got a jiffy tummy to reduce the amount of metformin without telling their GP. Really, you want to actually know whether or not they're taking what they should be doing. I'm probably cheating to suck eggs here, but it's something that I've experienced myself. So in other words, you need to ensure whether they're compliant with their tablets. Now, especially with the following drugs, metformin, because of the issues, you really want to take that with or after food. The glucose regulators, an example of which is ribagonide, you want to take that shortly before meals. The carbose or glucobase is known. The first mouthful should be swallowed with before food or chewed with the first mouthful. The glucosames, again, take at the same time each day. Finally, with the insulins, the thing that you would generally tend to ask a patient who's got type 1 diabetes, we covered this at length last time round, you'd want to confirm the insulin type with the patient, confirm the ejecting devices, make sure they are using it correctly as well. I mean, the chances they probably are. Reinforce the use of single-use devices as well, to make sure that, for example, the lancets that they're using are used on a single basis or singular basis as opposed to a multiple basis, which could increase the risk of infection. Make sure that they've actually got resources for sharp disposal as well. And if they don't, they may need to contact the council as well to get rid of those sharps. And finally, with self-testing, with the local guidelines as well, what the recommendations are for self-testing, and also to make sure if they are testing that the strips are compatible with the machines, and also the technique that they use as well, and all that they understand the results of their readings as well. And we'll come on to that in a little bit as well, especially with HbA1c reading, which we'll talking about in a few minutes' time. There's a number of things there you can look at in terms of concordance, in terms of medication issues with regards to patients with type 2 diabetes. Now, let's go on to diabetic screening. The first thing you need to bear in mind is to make sure that they've seen a diabetic nurse in the past 12 months. They need regular reviews, obviously, because of their condition themselves. So if they haven't seen the past 12 months, then you need to make sure they have an appointment to see them. Now, HbA1c is quite an important one. Now, what you want to do is make sure they've got a reading every 2 to 6 months. Now, generally, if somebody's HbA1c is quite high, you'd want to do it more often. If it's reasonably within the range that's recommended, you could do it every half a year or so. Now, the aim is to get it between 6.5 and 7.5. That's general rule of thumb. Now, even now, and there's a level which is mentioned by the FC. Generally, most people are used to the percentages, but that has changed recently. In other words, you don't tend to not to use percentages anymore. And if you're confused, which I probably have confused you more than I hoped I should calculate the diabetes. You've got the web address here, diabetes.co.uk/HbA1c-units-converter8.html. And what we'll do is you can enter the reading. So, for example, this one here, if we go by lower level, sorry, I don't know why that's gone on. Okay, that's better. You want a lower value. Okay, so let's say, for example, it's 6.5%. That's the equivalent of 6.5. That's the equivalent of 47.5. So you will. This is standard scale now. It used to be the percentage, but this is a standard scale. So if you're unsure, you can always go onto something like this. There's loads of other calculators out there that will convert the two from one to the other. Now you'll also see, for example, you've got a general sort of scale here as well, which is quite nice. So you've got a green, amber, and red there as well. So let's put something which is rocketing high. Let's say 14. Okay, that is 129 on the general scale here. I can see that the marker's gone up to red here as well. That's actually quite dangerous. So generally, as I said, you want to keep it around about 6.5. That's sort of like right on the border between good and not so good. I suppose you can call it that way. But very good calculator, worth a look at if you can manage that. Now let's go back into the other one. HbA1c important, but also what's probably more important is making sure the blood pressure control is there. If you've got a blood pressure machine there, you could take the reading if you wanted to. Ideally, you want to keep a blood pressure of less than 130/80. Cholesterol, again, much more important in patients with diabetes, especially with increased risk of cardiovascular disorders. You want to try and aim for one less than 5 millimoles. If they're not taking a statin, then you may want to take a reading here. But it's quite important they have their cholesterol checked on a regular basis and making a statin if necessary. And finally, self-testing. Now, I've gone over this in details before. So if they're self-testing, ideally if they're on metformin, the sort of you would want to actually talk to the patient about to make sure the machine is working, to check their strips and compatibility, and also to check their knowledge of bloods as well. So when they're taking the reading, what do they do with it? And again, refer them on to a calculator like this one to make sure they understand the importance of the reading that they've got. This is HbA1c, but there's blood glucose calculators, which is generally what they would use in this sort of self-testing regime as well. Now, urine protein tests, you would want to take that annually, and if there is protein in the urine, it may indicate the initiation of ACE inhibitors. Other annual tests, which we want to make sure that the patient has also had, the regular sort of eye tests and the foot care. Now, you'd want to. It's not an annual test, the foot care, but you'd want to use that probably every 2-3 months or so. You want to make sure that the nails are trimmed, that there's no sort of damage on the soles of the feet, which could lead to problems later on. So the other things you may want to check in the MUR is the issues of recurrent thrush. If there's recurrent thrush occurring, that could indicate that the diabetes itself is not very well controlled, and therefore you may want to recommend to the patient that they see a diabetic nurse again. And finally, erectile dysfunction. Now, this is going to be quite a sensitive one to bring up, especially for men. But if you are able to, this is quite an important one because it's quite a large source of problems for example, for depression or something like that. Because it could be quite depressing. And in fact, patients with diabetes can be prescribed the phosphodiesterase inhibitors, such as things like, for example, Viagra, sildenafil, CDS, and tadalafil, those sort of things, on a selected list scheme. So in other words, if the prescription's got SLS on it, if you've got diabetes, you're able to be prescribed this on the NHS. So it's something just for you to bear in mind there. So we've covered 3 issues: so medication issues, concordance, and diagnostic screening. Let's go on to some other. I mean, these are anything else that you could mention in our situation. And it's the sort of thing that you would tend to talk to patients about on a regular basis if they have diabetes. Main things: make sure you eat regularly and you limit the amount of sucrose. It doesn't mean to say you can't take any sucrose. It means just to control the amount that you do take. And the usual sorts of things: increase your fibre, reduce the salt and fat, 5 fruit and veg, and inclusion of oily fish. I mean, the idea behind that is to reduce our cardiovascular or any significant effect. Now, management is an important thing, especially if they're on things like soften our ureas, and the other sort of thing. Smoking cessation. I mean, the best thing you can ever do for any patient is to stop them smoking, and especially a patient who's got diabetes. Now, you're unlikely to find many patients who are smoking who have diabetes, but you still do, and you know, you can take the opportunity there to refer them on to your smoking cessation scheme if you have one, and if you've got one on weight management, again, you can take the opportunity to refer them on to that as well. The general alcohol advice, you know, to make sure they're not over drinking, standard sort of units, you know, less than 14 for women and less than 21 naturopathic for that now. But that's the sort of advice we tend to give. And also to make sure you carry sugary snack if you're on a non-metformin. So if you've got a risk of a hypo, you probably want to carry something like that around as well. There are a number of different things that you can signpost patients to, but the two I've picked out, which I've used in the past as well, is Diabetes UK, and so I'm going to go on this again. So that's an example of a Diabetes UK page, really good. It's got loads of information on it. You know, insurance directory. You've got for a shop there. You've got information on type 1, type 2. Loads of different things, you know, that they may want to have a look at. I mean, I've probably heard of it, but if they haven't, good one to actually, and they actually even do leaflets in different languages as well. So if your patient doesn't speak English very well, you could still refer them on to that, and they can provide information in different languages, which is really useful, really. And finally, there is another issue which is it's going to be a thorn in many people's side, is sharps disposal. Now, pharmacies and so on meant to take in sharps unless the only time when they should be doing it is part of a legal exchange scheme for methadone or drug abusers. So you're not really allowed to take in sharps. Some GP practices do it, but again, you know, you're not going to get many GP practices who will take it in as well. So you know, it might be an idea to have your council number handy, so they can arrange directly with the council to remove used sharps bins from their premises, from their homes. Something called the sick day rules. Now, think about it. If you've got diabetes and if you're going to be ill, you might not eat very well, and you might need to increase or change the way in which you test yourself until actually back to normal again. So, if you're very ill, I guess generally tends to correspond to patients who are non-metformin. So, let's say for example you've got a patient who's on glycosides and they tend to be quite ill. So, what sort of things would you want to watch out for? See, in one second, they're not eating very well as well. That's the main thing. So, the first thing you want to do is make sure that they test more often. It can be up to 4 times if needed. Just to make sure that the blood glucose throughout the whole day is at a reasonably steady rate and is not increasing too much and not decreasing too much. Then you want to check for ketones if you're on insulin and you've got type 2 as well. Now, ketones in the urine especially is the body's way of getting rid of degraded proteins in effect. So it's actually not a very good sign if you've got ketones in the urine. And it's kind of, and especially if you're violently sick as well all the time, which is got on here, you're more likely to get ketonuria. So if you've got keto sticks, possibly you might even want to use that on a reasonably regular basis, just to make sure that you're not entering that phase. The most important thing is not to stop taking your insulin or your tablets as well. That's probably the most important bit of information you can give to them. And finally, just to make sure that everything's working properly, the plumbing's working properly, drink plenty of fluids. That actually helps to flush out. If there's any ketones that are building up, it'll help to flush them out as well. And also will keep you hydrated as well. So in a nutshell, those are sorts of things that you could possibly speak to a patient with diabetes in an MUR situation. It's probably a lot more information you're likely to give, but something nevertheless that you can use. I suppose one thing that I have missed out on are things like aspirin and various other drugs as well, such as statins, etc. The sort of advice you would want to give with them as well. But that will be something for maybe another session next time round. So thanks again for watching this. Again, I do apologise for the issue that cropped up last week. Hopefully it won't happen again, but hopefully you found this webinar useful. Again, thank you very much, and I look forward to hearing from you soon. By the way, if you do require any more support, if you do want me if you want to ask any questions or anything, my email address is this, listen.shah, at bad typing, pharma+ltd.co.uk, and the number is 020-8863-3335. And look forward to hearing from you. Bye bye.